So this is a small overview of the presentation. So if we talk about implantation failure and recurrent implantation failure, the first thing which we need to discuss to a high extent is the definition. Then in the second part of the presentation, we can discuss some diagnostics. For the therapeutics, I also selected the scratching case to be discussed more into detail. And then, of course, we will reach the conclusion of the presentation. Next slide, please. So as I am presenting from Brussels, I am showing you the outcomes in Belgium, actually for a nice patient population under 36 years of age, first cycle, no PGT. And what we actually encounter is that these success rates are quite stable over the last years. And this is something that we would all like to increase, of course, but which seems to be very difficult. Next slide, please. Of course, when we perform IVF and when we transfer an embryo, there are many keys to success in IVF. We need the optimal endometrium, we need the embryo, and then these two need to interact in a nice way with each other to reach a pregnancy. Next slide. If we perform a stimulation, next slide, please. Thank you. If we perform a stimulation,
انت هي ما عندهاش كنترول. ده اللي عارف اعمله دلوقتي في
اكرم ما تتكلمش. اكرم انقل بس السلايدز لما تقول لك بليز.
I don't have control over the slides. I'm sorry.
Yes, don't worry.
Yeah. No, I'm sorry. So if we perform IVF and if we perform an ovarian stimulation, we ask a lot of the endometrium. Not everything is in sync. And what we expect is that the window of implantation, that this ideal moment of receptivity is probably hampered by the ovarian stimulation and by the high hormones that we encounter to reach the eggs. Next slide. If you look at the pyramid on the next slide, you see that a lot of embryos are lost around this moment of implantation. So estimated about 60% that we lose just prior to implantation or just post-implantation, but definitely before reaching a positive pregnancy test. Next slide. Then we reach, of course, the definition, because it's very difficult to have guidelines for diagnostics, guidelines for treatment. If you look at literature, it is quite chaotic. And for me, how I feel it, one of the main issues is that we lack the uniformity in the definition. When is a patient an implantation failure? Is this after 2 cycles, after 3 cycles? Do we take into account a certain number of embryos transferred or a combination of both? In the paper published in RBM Online in 2014 by Polanski, this problem with the definition is acknowledged, and then he proposes a definition which was on the next slide. Yeah, which was, of course, the failure of 2 consecutive cycles in which 4 cleavage embryos did not give rise to a positive HCG or 2 blastocysts. Of course, expecting that all of these embryos are of good quality, because if you talk about implantation failure, we are always in search for a problem with the uterus and with the endometrium. However, is this definition a real, valid definition? Next slide, please. Presented by Somiliana more recently, this is a mathematical model taking into account the expected success rate and the expected prevalence of repeated implantation failure. And of course, if we have a patient who is older, we do not expect this baseline ongoing pregnancy rate of 30%, which is the blue line. We know that it will be more difficult to get an older lady pregnant. And then you see on the curves that the risk of having a false positive diagnosis of RIF becomes more and more important. in all of the previous definitions, this impact of the age is not taken into account. On the next slide, you will see a newer definition in which next slide, please, in which the definition of repeated implantation failure is actually not valid any longer when the patient is above 40. Next slide, please. So here you see that actually to meet the definition, she needs to be below 40, more failed cycles, and then 4 good quality embryos, but not really specified whether these embryos should be blastocysts, yes or no. So I think that we have a lot of work to do on reaching a correct definition, and this would definitely be of help for future research for this difficult patient population. Next slide, please. Then, when we encounter a repeated implantation failure patient, what can we do? Here you see some of the routine practice exams. Of course, we have ultrasound. We already heard a lot on how to perform a correct ultrasound this evening. But when you want to predict the chances of your patient becoming pregnant on ultrasound, the structure of the endometrium and the thickness of the endometrium seem not to be that valid in clinic to guide prediction. If we go a little bit more into depth, there is indeed hysteroscopy, and specifically for repeated implantation failure patients, there was the trophy trial. On the next slide, you will see No, is there another? Yes, you can go to the next slide, please. And another slide, the next one, please. Here you will see in detail the data of the trophy trial, in which a hysteroscopy was performed after at least 2 failed cycles. But actually, in this large randomized control, there was no difference between the group that received the hysteroscopy and the group that did not receive the hysteroscopy. Next slide, please. If we go to the endometrial biopsy, longer time ago, we worked with the noise criteria, who also show to be inefficient to guide clinical practice. And then now, quite revisited, is the story of the chronic endometritis. On the next slide, you will see some more information. But again, the problem with the definition, because first of all, we do not really know what an implantation failure patient is. And then maybe chronic endometritis is associated. But on the left side of the figure, you see that each and every research group actually uses other definition, other counts of plasma cells. Interesting and newer in the field is the link between the microbiota and the chronic endometritis. And this is something which should be evaluated more in the future. But in the Liu paper published recently, 2019, they detected an association between the presence of a chronic endometritis and the microbiota on the uterine fluid. Next slide, please. Then we have to talk on the molecular diagnostics of the endometrium, because if we are able to have a reflection of the RNAs, of the messenger RNAs which are in our endometrial cells, then maybe we can get in touch with the functionality of the endometrium. There are microarrays, but more and more everybody is going to sequencing, giving us an entire image of all of the functions, of all of the pathways present and active in the endometrium. Next slide, please. One of the known tests is, of course, the ERA test, the endometrial receptivity array developed by Genomics, with a very nice concept stating that not for each and every lady, the window of implantation is at exactly the same time. And claiming that a biopsy in which a certain number of genes are checked, more specifically 238, that might have the possibility to classify the endometrium in a receptive phase, which we want if we do a blastocyst transfer, but also the possibility of your patient being pre or post-receptive. Next slide, please. As a concept, this is very interesting because if it's only a problem of timing, of course, we can adapt in clinic and we can perform the transfer a little bit earlier, a little bit later. So a very interesting hypothetical concept, but the test is on the market since 2014. And actually the hard evidence showing that it is beneficial in clinical practice is still awaited. On the next slide, you will see some preliminary data that have been published quite some time ago, but you will see that the sample size in this first study was quite limited, 25 patients, with only a couple of them being out of phase and having a corrected embryo transfer afterwards. So we cannot really rely on these 25 patients with 8 patients out of phase to prescribe an ERA test for all, of course. Next slide, please. This test has been evaluated by other research groups as well. One of the most recent papers is the paper by Neves published in JARC last year, in which they checked the outcomes after ERA, after PGTA, and in donor cycles, so where we expect the embryos to be, of course, of good quality. On the next slide, you will see their outcomes for the euploid blastocyst transfer. And on the bottom line, you will see that there was no difference in the outcome between the ERA and the non-ERA testing. Of course, this is retrospective, but still it is what we have at this point in time. And on the next slide, you will see what they detected for the donor arm of the study. And unexpectedly, probably for iGenomics, the group that received ERA performed less outcome, less success after the transfer than the routine group. Of course, this is retrospective, but we really need to wait for a valid RCT to confirm this and to use this on a daily basis in clinic. Next slide, please. Another molecular diagnostic test which is on the rise is the testing of the microbiome because of the evolution in techniques. This is something which is really trending. Next slide, please. It has been hypothesized, and it could of course be possible that the immune system, which is very important for implantation, is associated with certain microbiota which are present in the vagina or in the endometrium, and that by checking the microbiota, we could predict the outcome of our IVF treatments. Next slide, please. What we actually expect, and these are data from our colleagues in the Netherlands, is that a more dysbiotic profile gives you a less optimal outcome. So you see it on the right side of the figure when the microbiota are more chaotic, when they are not lactobacillus dominated. The class 4, these were the patients having less positive pregnancy tests after treatment. However, next slide, we in our research group, we had quite some basic remaining research questions on this microbiota. And this is why we are currently performing a large prospective study in which 300 patients will be sampled multiple times over their IVF treatment. So at intake, at oocyte retrieval, at embryo transfer. And what we really would like to address in this study are quite some technical issues with the technique. Next slide, please. The slide after the overview of our study. A little bit further, please.
كمان يا أكرم.
Yes, one more. So at this year's EFRE meeting, we have presented two preliminary outcomes of our study. And what we actually see is that ovarian stimulation is associated with more diversity in the microbiota of the cervical swab. So on the left side of the figure, you see the profiling for the entire sample set of patients. On the right side of the figure, you see a subgroup analysis of patients that reached a live birth after the treatment and patients that were not pregnant. For both of the groups, we see that the diversity increases upon stimulation, and it looks, but it is not significant, that this diversity increases more when the patient does not have a positive HCG afterwards. But this is something to be rechecked at the end of our study. Next slide, please. Another concern that we have with the microbiota sampling as proposed today in literature is the analysis of the intrauterine sampling. Because this is a very low biomass sampling, it is very much prone for contaminants, to be completely biased by contaminants. And indeed, we have compared two extraction protocols, one routine protocol, but then another extraction protocol, which is specifically developed for low biomass samplings in a clean room with a lot of precautions to avoid contamination. And you see that the automated extraction and the routine analysis of intrauterine microbiota is severely hampered by contamination. And we were able to show that an optimized protocol gives a much higher prevalence of a relevant detection of microbiota in the uterus. So quite some more basic and technical questions to be addressed again before using these techniques each and every day in clinic for our patients. Next slide, please. Of course, in most of the cases, the transfer cycles fail. We as doctors cannot explain this to our patients, which gives rise to chaos and which gives rise to the fact that patients accept off-label treatments and do this outside of a research setting. It's a very difficult problem to handle in clinic. Next slide, please. Here you see an overview of add-ons on top of the IVF treatment, things that are asked to us each and every day in clinic by our patients. For none of them we have valid evidence to use them, but of course very difficult to refuse it to your patients after multiple failed cycles. But in the end, we should really try to stick to evidence-based medicine, and we should invest time to explain to our patients that we do not have any evidence to prescribe these treatments to them. Next slide, please. Next, you can go to the next slide. You can go to the next slide. These were just all examples of the very first slide. Then we come to the scratching case, which we already discussed in the previous question round. So actually, the hypothesis comes from rodents, from guinea pigs, and from mice who have a completely different residualization and implantation than humans. The most accepted idea on why the scratching could have worked is that there was a recruitment of immune cells ready to act at the level of the endometrium to assist in the embryo implantation. The next slide, please. And the last, one of the last meta-analysis was in 2015 by Nastri, stating that stretching might be of use when there are 2 or more failed embryo transfer cycles. However, next slide. At exactly the same time, another author claimed that it was impossible to perform a meta-analysis, as each and every research group was actually scratching in a slightly different way, which is depicted on the next slide. So the patient population is of course of importance, because should we scratch in the general population, or should we only do it when we expect a problem with the implantation? When is the moment to do it? And then how should we do it? On the next slide, you will see an overview of most important papers that are published today. And you see that they are scattered all over the figure. There is hysteroscopy, there is the PIPL scratching, and the moment of scratching differs. There are two very large trials in this figure. It is for the hysteroscopy, the trophy trial by El-Touki, published in the Lancet in 2016, the paper which we discussed in the beginning of the presentation. And then, of course, we need to have a look at the Lancet paper, New England paper of 2019, that showed no difference in between the groups. On the next slide, you will see some more information. So here you see the main table of the Lancet paper, no difference between the scratch and the control group. And on the next slide, they also did not show any difference in a subgroup analysis. Another scratching trial was ongoing and was published at this EFRE meeting very recently, 2 weeks ago. A study, an RCT of our Dutch colleagues from the Netherlands, scratching after one failed cycle, in which they also show no difference in between the groups. Next slide, please. This is the details of our own study. So, I'm sorry, on the right side of the figure, you see the zoo paper on which our ID was based, actually showing nicer results after scratching. So we scratched during the follicular phase, and we aimed at 360 subjects. Next slide, please. Here you see an overview of our inclusion and exclusion criteria. So it was a pragmatic RCT. We did not specifically look for RIF patients. So also first ranks were included, an important item of the study, of course. Next slide. This is an overview of the study. So the patients were scratched during the stimulation, and it was an RCT with two equal arms. They were followed up. Primary outcome was the clinical pregnancy rate, but we followed them up until 6 months after the treatment. On the next slides, you will see our outcomes, and you see the reason why we needed to stop our trial prematurely, because on the second pre-specified interim analysis, to safeguard the safety of the intervention, we encountered a higher miscarriage rate, which made us conclude that it was unethical to continue the trial any further. On the next slide, you will see an overview of the outcomes up until 6 months, and there you see that there is no difference, also not at the longer term, of the scratching that we did in these 200 patients. Next slide. So in conclusion, implantation is very complex. You have the embryo side, you have the endometrial side, and then they need to interact with each other. We are at this point in time quite limited with the diagnostics that we can do for the endometrium. It is difficult to use them to guide clinical practice. And although I know that in the definition of implantation failure, we talk about good quality embryos, these good quality embryos, they do not mean everything, because often we do not know anything about the genome, but even if they are checked by PGTA, there are many other factors that can hamper the embryo quality, while the embryo at the level of the morphology looks very nice. Next slide, please. So here you see that even for the euploid embryos, there are quite some poor morphology embryos. So there is definitely more than these two. On the next slide, if we would aim for PGTA cycles in an attempt to increase the embryo quality for repeated implantation failure patients, we need to take into account that often it is very difficult to reach these euploid embryos, and that we will encounter many patients having difficulties reaching the blastocyst stage and having an euploid embryo to be transferred. So as a general conclusion for the repeated implantation failure case, I think that the endometrium could play a role, but that definitely we should also more focus on the embryos, although them being described as of very good quality in the definition. This was the end of the presentation. I'm happy to welcome your questions.